3, 2, 1. Go live.
بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على سيد الخلق وسيد ولد آدم سيدنا محمد وعلى آله وسلم. Good evening everybody. Ramadan Mubarak to all of you. I am Ahmed Al-Mitwalli Al-Kutbi, founding president of the Society of Saudi Dialysis and Transplantation. I'd like to welcome all of you to this evening webinar, which is the second webinars this month, which is one of a series of educational webinars related to COVID-19 outbreak planned by your society. Tonight, we have with us a pronounced speaker, Professor Andrew Davenport. He's going to talk about hemodialysis and critical care nephrology during COVID-19 outbreak. This webinar is sponsored by Fresenius Company, so I would like to take this opportunity to thank them for their continuous support, and they are always a partner to our society. Our moderator this evening is our colleague, Dr. Wissam Al-Badr, a well-known nephrologist. So I wish you all a rich and great scientific experience tonight, and I wish that you all join us in our next webinars. So I urge all of you to check the Saudi Society of Nephrology and Transplantation website, and please do register. All our webinars are credited by 2 hours CME by the Saudi Council for Health Specialty. With no further delay, I would like to invite Dr. Wissam to start this meeting. Thank you all, and good luck, and God bless you. One small note, please, if you have a question, at the bottom of the screen, you will find Q&A. Write your questions on this part. Dr. Wissam will screen the questions and then forward them to Professor Davenport. Thank you.
Good evening, everybody. I'm very happy to moderate this webinar, starting with Professor Andrew Davenport. He's a well-known professor of dialysis and ICU nephrology in UCL Department of Nephrology since 2004. He also functions as a consultant nephrology at the Royal Free Hospital since 2003 and the University College of London. He is also the president of the International Society of Hemodialysis since its establishment in 1999. He has more than 450 research work with 10,000 plus citations for his research contributions. So we are pleased to have you with us and definitely excited for both lectures. We're going to start with the first one, which is managing patients with end-stage renal disease on hemodialysis with COVID-19. Again, I want to reiterate what Prof. Mitwalli mentioned, which is we will be taking your questions once you place them into the Q&A section right after the talk. Thank you very much. To you, Professor Andrew.
Well, thank you very much for that very kind introduction. And I'm just going to talk today about some of the problems that we've encountered when we've had an outbreak of coronavirus in our own centres. One of the issues for us is, first of all, is how to get the slides to move. So if I go down, page down, no, it doesn't like that. Okay, so we all know that COVID-19 is a respiratory virus. and therefore the main mode of transmission is by aerosol. But it could also be transmitted by what we call fomites. That is, the virus lands on a surface. And the information I have from our own virologists is that it's possible for the virus to survive on a surface for up to 72 hours, so almost 3 days. So these are the major routes of transmission of the virus. Now, it can also be detected in blood, it can be detected in urine, and interestingly also in semen. So although we think of it as a respiratory virus, there are other possible ways of how it could be, if you imagine, transmitted, particularly in terms of fomites. And if we think of some of the risk factors for the transmission of COVID-19, you can think about how modern day society works in terms of the risk of people catching it indoors. We think that if you're within a meter of a person and for about 15 minutes to 20 minutes, then you have an increased risk of transmission compared to a much lower risk of transmission if you're outdoors in the open air. And then again, the issues are one of housing density. So if you live in big cities with lots of flats, very close social housing, you're more likely to transmit this virus than if you're living out in a rural environment. And then again, the concept of multiple contacts versus social isolation. We know that this virus has this spike protein, and the spike protein interacts with an ACE receptor. And interestingly, the ACE receptors, that they increase as we get older. And therefore, younger patients are less likely to get infected than the older person. And again, men tend to have more of these ACE receptors in their respiratory tract than do women. So again, it's more likely that males will get infected compared to women. And then there are other issues. Certainly in the UK, there's an issue in terms of ethnicity, that patients or people from a Black and ethnic background are more likely to get COVID-19 than those who are Northern Europeans. And then again, the question is, how do individual genetics affect the severity of the illness? And these are issues that are still ongoing. And in the UK, the majority of our patients are now over the age of 65 on hemodialysis programs. And so if you think about it, why should elderly hemodialysis patients be at risk? And certainly in the UK, families have broken up, and therefore often elderly relatives often end up living in nursing care homes. And these have communal areas where people gather together to eat and to have afternoon events, etc., to keep their minds occupied. And the alternative is that elderly people live at home, where they have carers who come into the home and help them to get out of bed, to get washed, to feed them, etc. And often there are multiple people going into the elderly person's home. So you can see that in the UK society, that older patients are more likely to have multiple contacts compared to younger patients. And in terms of our ethnic minorities, particularly patients who come from the South Asian environment, they're likely to live with the family. So you're likely to have elderly grandparents living with living with sons and daughters, and then living with grandchildren. So multi-generational families for our South Asian communities. And in the UK, we often provide hospital transport or transport to and from the dialysis centres. Now, we can't afford to send a private car for every individual patient. So therefore, we tend to transport 3 or 4 patients in a vehicle, in a taxi, to and from the dialysis units. Or if their patients are in wheelchairs, that's what we call supported transfer. And again, there'll be 2 people coming to help the person get into a vehicle, get out of the vehicle, etc. And again, having close contact with the patient. But what about younger patients? So why should younger patients also be at increased risk of developing COVID-19? And I think therefore you have to look at the prevalence of chronic kidney disease. So certainly in the UK, we find that the prevalence of chronic kidney disease is much higher in those who are living in deprived socioeconomic communities, those who are living in crowded living accommodation, sharing facilities, sharing kitchens, sharing bathrooms, and in some cases even sharing bedrooms, etc. So there are quite a number of risks in terms of how dialysis patients meet other people outside of their family. And then the issue is, well, what about public transport? We do encourage people to come on public transport. But again, if you think about certainly in a big city like London, the buses are very full, there are lots of people there, and the London Tube, for example, it can be packed at times. Again, very, very close contact with lots of other people. And then if you come to the dialysis center, because we're bringing patients in terms of communal transport, we often have a number of patients all arriving at the same time. And then they're going to sit waiting till it's their turn to be put onto the dialysis machine. So you have patients sitting in close proximity. And then at the end of the dialysis session, what you'll have is patients waiting for other members of their group to be transported back. And at the same time, there'll be new patients coming in for the afternoon shift, etc. So again, in the dialysis unit, we've got patients sitting together and therefore can spread diseases. And we know, compared to, say, peritoneal dialysis, that certainly in Northern Europe, the rates of pneumonia, lower respiratory tract infections, can be 30 times higher for patients having hemodialysis compared to those who are, if you imagine, isolating at home with peritoneal dialysis. And then the other issues are to think about how your dialysis unit is designed. So here, for example, on the left, you can see a very long single room with lots of dialysis stations. Whereas on the right, you can see one of our dialysis units, and you can see that there's only a few number of patients in this center. So this center is designed to have, if you imagine, several different types of small units making up a whole big center. And if one's got a respiratory virus, you can imagine that a respiratory virus can spread easily in the center on the left, because everybody is going to be breathing in the same air. Whereas on the right, if we divide the dialysis unit up into small sections, it's less likely to spread a communicable virus. And the other issue to think about it is, how close are the dialysis machines? You can't quite see, but in this left-hand slide of this very long room, these dialysis machines are quite close together. Whereas in this dialysis unit of ours, you can see here's a patient in a bed, there's one of our nurses, there's a dialysis machine, and then there's a big table between that person's space and the next dialysis person. So again, a big space between the different stations. And of course, again, there's close contact with the nursing staff and other healthcare workers, because they're going to put in needles, they're going to connect patients to and from the dialysis machine through central catheters, etc. So there's close contact with the healthcare workers. So if we think about how COVID-19 presents in the general population, you can see that the majority of patients who become symptomatic develop a high fever. And this can often be up to 39 or 40 degrees. A great number, almost 2/3 or so, will develop a dry cough. And then other patients will generally feel fatigued. They may have muscle pains, sore throat, shortness of breath, and they may have diarrhea and headache, etc. And when we looked at our dialysis patients who became symptomatic, the major finding we found was that most of them complained of shortness of breath, by fatigue, and then fever, and then headache and diarrhea. So we had a slight difference in terms of the presentation of our patients compared to, say, what's reported with the general population. And one of the differences or difficulties in dialysis patients is that if they're complaining of shortness of breath, we have to decide, is this going to be an infection or is this going to be pulmonary edema? And here's the typical chest X-ray of one of our dialysis patients, and you can see the patient has a large heart. There appears to be some degree of upper lobe diversion of the blood vessels, but actually this patient turned out to have COVID-19. So there is an issue in terms of making a differential diagnosis between volume overload and patients having pulmonary infection due to viral infection. In our own screening system, we screen for a number of different viruses. And when we first started seeing COVID-19 patients, it was at the end, if you imagine, in the wintertime in the UK, we naturally have respiratory viruses going around. So we'll have rhinovirus, as you can see here, parainfluenza, influenza A and influenza B, respiratory syncytial virus, human metapneumovirus, respiratory adenoviruses, and natural coronaviruses, which occur in the UK, and pericovirus. So one of the issues for us was when patients came in and had what we thought was going to be a viral infection, as to whether this was going to be COVID or actually was going to turn out to be influenza A or parainfluenza, etc. So we had to screen patients for a whole cohort of viruses. Now, in terms of helping in terms of differential diagnosis, then obviously the most important thing is the low white cell count, the leukopenia. And this is usually a very low lymphocyte count. And the other things we noticed was abnormalities, particularly in terms of things like D-dimers, in terms of high levels of fibrinogen. And in the biochemistry, we would measure things like brain natriuretic peptide to give us an idea about fluid balance, fluid control. Ferritin was often elevated, but often up to 5 or possibly 10,000. Certainly not to the levels you'd see with one of the secondary hemophagocytosis type syndromes. And again, in some of the patients with the muscle aches and pains, we'd noticed there's an increase in the creatinine phosphokinase in terms of a small muscle breakdown. And again, you can see here, here's one of the typical sort of CT scans of one of our patients with COVID, showing quite significant respiratory damage. And one of the things you can imagine is that just because somebody has a primary respiratory viral infection, you can see it's going to be very easy for that patient then to develop a secondary bacterial infection on top of the primary infection due to the extensive damage in terms of the lung. So the first case we saw was on March the 7th. And the UK policy at that time was basically to carry on as normal. In fact, the government was asked whether to hold a very large horse race meeting in Cheltenham that attracted around about 250,000 people attending the horse racing. But by March the 16th, the UK government announced that if a patient, or if a person, I should say, developed a fever or a cough, they should self-isolate themselves at home for 7 days. And then if somebody in the same household with a patient who developed a fever or a cough should then isolate themselves for 14 days. So what this meant was that these patients were to stay these people were to stay at home and not come to the hospital unless they felt really unwell. And similarly, medical staff, if they developed a new cough or a new fever, again, were told to self-isolate at home for 7 days. If they then felt better, then to return to work. So this was all happening in the UK without any, if you imagine, testing to see whether patients or members of staff actually had COVID-19. And then March the 23rd, with the number of cases escalating in the UK, the government decided then to have what we call a lockdown and basically told shops and businesses to close down and people not to come to work unless they are part of what they consider to be either an emergency service or a service that just had to run. And therefore the UK message was simply coronavirus, stay at home, protect the National Health Service, i.e. don't come to the National Health Service, and help save lives. And the idea behind it was that the only reason to leave home were to shop for basic necessities, such as pick up medicines and travel to work only when it was absolutely cannot work from home. Exercise once a day and do that alone or with members of your own household. And the key issue was not to meet other people, even friends or family, and to wash your hands. And this was emphasized a number of times in terms of the importance of strict hand washing. Now, this is looking at some of the cases in our own unit. And you can see here that this is the number of cases per day on the left-hand side. And quite quickly, we suddenly were seeing sort of over 10 cases a day, and the peak to around about 15 cases a day. And then you can see over time, the peak falls. And in purple are the number of people with transplants who are presented. As you can see, there are a small number of transplant patients who came into the hospital. A lot of transplant patients, if they had symptoms, were simply asked to stay at home. There were some changes made in terms of the medicines for transplantation, in that those patients taking drugs such as mycophenolate, then these agents were stopped and patients were given prednisolone instead. In green are a small number, as you can see, of peritoneal dialysis patients in the green bars, and in blue are patients with chronic kidney disease. Now, it turned out that in the UK, patients with chronic kidney disease stages 2 and 3 tend to be looked after by the family doctor. And therefore, the hospital only tends to see patients with chronic kidney disease stage 4 and stage 5. So the blue bars are reflecting patients with stage 4 and stage 5 chronic kidney disease not on dialysis. Now, not surprisingly, quite a number of these patients with chronic kidney disease stage 4 and stage 5 developed an episode of acute on chronic kidney disease and needed to start dialysis. And then the red, which is the predominant color, you can see these are hemodialysis patients. So I think on the worst day here, you can see we admitted 11 of our hemodialysis patients symptomatic of COVID-19. And if you look at what happened over time, we have in the red, this is looking at hemodialysis patients who were proven to have COVID-19. In the green, these are patients who we suspected, who either had COVID-19 proven on positive swabs, or who we thought were very likely to have had COVID-19. You can see this number certainly exceeds 200. In the blue line are the number of patients with chronic kidney disease. As you can see, that went up to over 100 patients. But down here is peritoneal dialysis. Very few peritoneal dialysis patients developed COVID-19. And in the red are a number of our transplant patients. Again, much lower than you can see compared to hemodialysis or chronic kidney disease. And if we think about the issues in terms of patients and staff, one of the issues is transmission between patients and staff to patients. And here's a picture here. This is our Prime Minister, Mr. Johnson, and he's pouring a cup of tea for members of the nursing team. And you can see often that the nurses will all sit together in a very small room in terms of where they'd eat together. And therefore you can imagine there could be transmission between your actual nursing staff. So one of the questions was how to make sure that our staff didn't get the infection. So as I said to you, staff were told to self-isolate if they had a new onset of fever or cough, and return if they felt well 7 days after the onset. But again, if a member of their household had a new onset of fever or cough, they should self-isolate for 14 days. And in terms of personal protection equipment, then if the patient had what we call general contact with a confirmed or suspected COVID-19 case, then they would wear a fluid-resistant surgical mask, they'd wear a plastic apron, and would wear some disposable gloves. But if they were dealing with somebody where there's a risk of an aerosol, and therefore a very high risk of transmission, then they would wear what we'd call a full face shield. The mask would be changed to an FFP3 mask. They would wear a gown and gloves and have, if you imagine, full protection. So initially in our dialysis units, our dialysis nurses and nursing assistants were wearing, if you imagine, the face mask, the gloves and the disposable apron. But we soon gave all our staff, I should say, face shields. So they all did have full face shields. Now, in terms of the risk to the healthcare workers, because again, one of the issues in the UK is that there were reports of doctors and nurses contracting COVID-19 and then dying. So there's great concern in terms of the quality of the PPE and whether it was sufficient to protect doctors and nurses. So this data comes from a hospital in London. It'll be published in The Lancet, I think, next week or the week after. And this is looking at the patients arriving in their hospital. So these are 7-day averages. And what they're looking at here is in red, these are new patients arriving in their hospital. And here's the total number of patients in the blue. In these bars here are the number of members of staff who are thought to have COVID-19. And what you can see here is that the bars certainly do not fall behind the public coming in with infections. So what this slide suggests is that the infection here in the healthcare workers is occurring at least at the same time as the general public, if not slightly before. So what one can say from this data is that there's no evidence from this study that there was an increased risk to the healthcare workers, that the patients weren't communicating the COVID-19 to the healthcare workers. So there seemed to be no additional risk in this study. Now, the problem, of course, is that what happens when your staff start becoming sick and self-isolating? And in some of our dialysis centres, we had 50, 60% sickness rates. I think at one stage we got up to 70% sickness rate in one of the centres. Well, what do you do if you've got such high sickness rates? How do you run a dialysis unit when nearly all your staff are off sick? Well, the hospital, because it was concerned about how to cope with the COVID epidemic, if you imagine, stopped doing routine operations. So we redeployed some of our surgical staff to help in our dialysis centres. Again, a lot of the medical clinics were cancelled. So again, we redeployed medical staff to help in our dialysis centres, and we also used medical students. And it was interesting. After all, what do you do with a professor when you send them to a dialysis unit? Well, the answer was we got them, if you imagine, to clean the beds, make the beds, help line the dialysis machines. So do, if you imagine, some of the very, very basic steps. So you could see some of our consultants, some of our senior consultants, professors, actually doing some really menial tasks, but helping to run the dialysis unit. Then the other issue is, well, if you've got less staff who can actually do dialysis, is it possible to reduce some of the dialysis sessions? Can we dialyze fewer patients? So we looked carefully at the intra-dialytic weight gains. We looked at things like brain natriuretic peptide in terms of volume assessment. And we looked at residual renal function and the pre-dialysis serum potassium. And therefore we moved patients who were dialysing 3 times a week, who had low weight gains, low BNPs, had some residual renal function, to twice weekly dialysis. Or in some patients who were dialysing twice a week, we actually moved them down to once a week. Now, because most of our staff were away for about 7 or 10 days, we could just about cope with a great deal of staff sickness, because this wasn't a permanent staff sickness, because most of our staff actually got sick relatively quickly together. So we suddenly, let's say, lost a lot of staff, and then after about 7 to 10 days, the staff started coming back, and we managed to make ends meet. Now, the other thing I need to explain to you is that in terms of testing for COVID-19, we're using an RNA PCR. Initially, all our tests were done by the National Reference Laboratory in Colindale, which is in our section in North London. But obviously, the National Reference Laboratory couldn't do enough tests. And so initially, we were limited as to how many patients we could test per day. And then the Royal Free Hospital, that's our own hospital, started to test patients and had the assay. And then next, part of the university, the Crick Institute at University College London, also developed a test. So suddenly over time, we were able to start testing more and more patients and staff. But what we did find was that with this RNA PCR, there was about a 30% false negative rate. And that was an issue in terms of how the samples were taken. So it's very important to get a deep throat swab, and also the timing. The quicker, or I should say, the sooner to the onset of symptoms, the more likely the test is to be positive. And if you wait till the patients get better, then the samples tend to be negative. And again, if you just look at in terms of the inpatients in our own hospital admitted symptomatically with COVID, you can see down here, here are chronic kidney disease patients in purple, transplant patients in green, and peritoneal dialysis patients in green. As you can see, most of these are less than about 10 patients, 10 inpatients at any one particular time, and over time this falls. Whereas you can see with hemodialysis, at one stage we had over 40 of our outpatient patients admitted to hospital. And over time you can see it came down, and then we had a later spike in terms of admissions. And if you think about how you're going to cope with this, is again, if you're suddenly going to admit a large number of patients, because that was like admissions, you can see here that in terms of daily total, in terms of suspected and confirmed cases, we had at one stage almost 80 patients in the hospital who required hemodialysis. And how are you suddenly going to provide dialysis to 80 patients? So again, there's an issue of then relocating dialysis nurses from our outlying satellite dialysis units to come back into the hospital to provide additional help and support. And if we look at what happened, if you look over here, here's hemodialysis. So confirmed, if we look at confirmed cases, so about 19% in terms of modality were hemodialysis patients. In terms of how many of those patients died, about almost 1 in 3 of our hemodialysis patients who were admitted to hospital died. But in terms of the total number of hemodialysis patients, the mortality was about 5.6% of all our hemodialysis patients. In terms of peritoneal dialysis, very few, as you can see here, of the dialysis patients were admitted to hospital. Of those who were admitted, yes, again, there was about a 30% mortality. But overall, the mortality in peritoneal dialysis was 1.8%. Again, if we look at our patients with chronic kidney disease, only 1% of our patients with chronic kidney disease on our program actually died. In terms of transplant, again, you can see here a very, very small number of transplant patients were admitted to hospital, only 1.5%. Of those who were admitted, again, there was a high mortality. But if you look at the mortality compared to our total transplant program, you can see this was very, very low. And again, what you can see here in terms of the hemodialysis patients, if we look at those patients who are on the transplant waiting list, you can see that the patients who are fitter on the transplant waiting list had a much lower mortality compared to the general dialysis patients. And if you think about, if we look at who died, you can see here in terms of male patients, so the total number of patients is in the white bars, and those who died are in the darker bars. So again, this issue I said before, that men seem to be more at risk than women. So we had more male patients, we had more male deaths. If we looked at the ethnicity, here are our white patients over here, and here are our ethnic patients. And although our white patients are more prevalent on the dialysis program, you can see more patients in the ethnic minorities actually caught COVID-19. In fact, it was more of our Black patients than our South Asian patients. And again, the mortality, the relative mortality was greater for the Black patients compared to the Northern European patients. And if we look in terms of how mobile patients were, you can see here, patients who were independent in terms of how they got to the dialysis unit, although more of them developed COVID, you can see the mortality was much lower. Whereas those who needed a Zimmer frame or a walking frame, and those who are in a wheelchair in particular, you can see, although there were fewer patients generally, the mortality was much higher. And again, if we looked at patients who came independently or had hospital transport, you can see the mortality was much, much higher in those that had hospital transport. We classified our patients according to the Canadian Rockwood frailty score. And again, you can see here in terms of mortality, mortality is much higher for those who are more frail compared to those who are more physically able. And again, if you look at in terms of age, you can see here that the patients who died tend to be older patients compared to those who survived. So what did we think about doing? Well, we asked patients when they came into the dialysis center, they were checked. They were checked in terms of, did they have any symptoms? Were they short of breath? Did they have a fever? Did they have any headache or diarrhea? And they were examined in terms of the temperature was checked, and we checked their peripheral oxygenation. If they are suspected of having COVID-19, they'd be swabbed. If they're symptomatic, we'd send them for hospital review. If they were asymptomatic, we'd decide whether they actually needed to be dialyzed that day or not. And a decision could be that we sent them home on that particular day. Now, how different dialysis units coped with this varied from center to center. So here's one UK center, and what they decided to do was set up some porta cabins and dialyze all their COVID patients in these porta cabins, keep them separate away from the rest of their patients. We didn't do that. We sent our patients back to dialyzing in their own satellite units. But in terms of our satellite unit design, there were differences in ventilation of the satellite units. There were differences in number of isolation cubicles, whether we could offer patients isolation bays, or whether we had to isolate, if you imagine, sections of the dialysis unit. So some of our dialysis units would be built in sort of 2 halves, others would be in 4 sections, etc. And again, if we look at, I say, I've shown you this slide before, so I'll just slip that slide. So what we asked our patients to do, first of all, was not to take any public transport, because we thought there's an increased risk of contracting COVID with public transport. We asked if it's possible to arrange for a family member to drive the patient to and from dialysis. And by doing that, that would stagger the time at which patients arrived to the dialysis unit. We issued all patients with a surgical mask and told them to wear it during transport to and from the dialysis center, and also whilst they're in the dialysis center. We gave masks to taxi drivers, so the people driving the patients to and from the dialysis unit wore masks. And in terms of ambulance drivers and ambulance crew, then they wore PPE. Slide. And so the other issue we also changed in the dialysis units, we said, if our nurses are putting patients on dialysis, they're in very close contact to the patient. They're close contact in terms of the patient's mouth and nose, etc. So even if the patient's wearing a mask, we said, no, we want our nurses to wear more substantial PPE. So our nurses would wear a mask, they'd wear a full face shield, we give them a gown, and we give them gloves when they're dealing with patients with suspected coronavirus or proven coronavirus. And if you look at what happened to some of our satellite units, so what you can see here in blue is was where we had an outbreak in one of our satellite units initially. And then you can see with these 3 satellite units, if you imagine there's a rise, and then there is, if you imagine, a plateauing off. Whereas in one other satellite unit, there's continuous. So we look at, first of all, at this unit that had the first outbreak. Now, this is our smallest unit. It has the capacity to dialyze 96 patients. And here is the waiting room now. But at the time when we had this outbreak, there was no gap between the chairs. The chairs went all next to each other. And this is a very small waiting room. And we think this is the reason why we had this outbreak in this satellite unit at the start. And once we realized that we were seeing patients from the satellite unit, the first thing we did was to separate patients sitting in the dialysis unit whilst waiting for dialysis. Now, the other issue here is that on this graph, there are 2 things to notice. One, this red line here, and this, if you imagine, the red and the green center seem to be going up together and then leveling off, and then suddenly seems to be a rise in this. And that's because we suddenly started to screen all the patients in that unit. And so as you can see, what we suddenly found was a number of patients who all were asymptomatic. And so this is one of the problems, that if you try and cohort patients who are symptomatic and swab positive, you may have patients who are asymptomatic, and can therefore still pass the virus on to other patients. So this is looking for asymptomatic patients in the dialysis unit. And the other issue is this other unit, which continued to increase in numbers. And over here, you can see this is almost 40% of a unit dialyzing about 240 patients. This unit has almost 100 patients positive for the virus. And what we found in this unit is that there was the windows could not be opened. There was no fresh air. And indeed, the air just circulated around and around the dialysis unit. So it's almost like being in an airplane where people are just rebreathing the same air all the time. And obviously there's going to be an increased spread in that type of unit compared to these other units where we can open up, have fresh air and new air. Now, having found that we had all these patients, the key issue then is, well, we can't keep all these people isolated forever and ever. So at what stage do we de-isolate patients? And we had some simple guidelines. So symptomatic patients should have shown some clinical improvement. And why that meant in terms of respiratory recovery and absence of fever for at least 2 days. And we elected to put our positive patients in isolation or cohort for 14 days. Initially, we then re-swabbed patients. And now that antibody testing is coming in, we'll now antibody test them. And if the antibody test was negative and the swab remained positive, we initially decided that we would put them into isolation either in cohorts and re-swab them a further 7 days. But we've now decided that after 14 days, we just de-isolate patients and let them go back into the general area of the dialysis unit. Certainly, we'd like one negative swab before de-isolating or positive antibody testing. And that's certainly before we send them back out from the dialysis units. So in terms of summarizing this, my key points would be this. Ideally, until you have antibody tests, you need to swab all your patients and staff, and you need to do it on a regular basis. We suggest twice weekly until you have reliable antibody testing available in your center. It's key to reduce communal transport to and from dialysis centers. And we thought it was really helpful that family members came to the rescue and helped transport patients to and from the dialysis unit. We need to ensure there's adequate spacing in the waiting areas. We needed ventilation in dialysis centers. We need adequate spacing between the dialysis stations, and we had to provide face masks for patients and provide appropriate PPE to all our staff. And of course, we had to isolate all our COVID-19 positive patients. But again, if you have almost 100 patients, the issues are, we almost had, if you imagine, half of a dialysis unit being COVID positive and the other half being COVID negative. And thank you for your time. So my message to you is to test, isolate, to track and to trace these patients. You know it makes sense. Thank you for your attention.
Thank you so much, Professor Davenport. And I'll go ahead and go through some of the questions that are already posted on the Q&A section. Just a reminder, if anybody has further questions, please post them on the Q&A section. So the first question is related to if you have a positive patient and this patient was discharged from hospital to home isolation, what is the precaution to be taken? Is it only a droplet and a contact precaution, or still there should be an airborne precaution as they are considered now cured by the new guidelines and they are asymptomatic, although the PCR was positive?
So the PCR being positive is a difficult issue, and that's because we're looking at a piece of RNA. And so the RNA could be that the virus is alive or the virus is no longer alive. And that makes it difficult to interpret in terms of the swabs. Obviously, once reliable antibody testing comes, then that will be much more helpful. So our position would be this, that if you've had a patient who's, let's say for the sake of argument, been admitted to hospital, has had symptoms, and now that the symptoms are resolved, the patient is feeling better, and they're discharged back to the dialysis unit, then we would normally still isolate the patient for 14 days from the onset of their symptoms. And the reason for that is that there is really good evidence showing that the virus is still being shed certainly up to 14 days. There are issues in terms of it's possible to recover the virus from urine, etc., from semen, much longer after 14 days. But we think the risks of actual transmission through fomites is actually quite small.
Thank you very much, Professor Davenport. I'll go to the next question. The question is about a patient on hemodialysis who presented with signs of potential overload with mild dyspnea, does not have a fever or any other symptoms. Would this be a patient that you would consider for screening of COVID-19?
So this is a patient who has no fever and is complaining of shortness of breath. So I think the first issue that we would look at is what's the peripheral oxygen saturation. So in a large number of our patients with COVID-19, we have found the oxygen saturations was down below into the 80s. So if the patient's oxygen saturation was only sort of 96%, 95%, etc., we would probably say this is going to more likely to be associated with pulmonary edema, and we're going to not regard them as high risk of COVID-19 disease. But if
Excellent, thank you very much.
But if the oxygen saturation was down at 80%, that'd be very important. And then the other issue is the blood test. Because again, if the patient has a low white cell count, in particular a lymphocyte count of 0.5, 0.6, and there's no other obvious reason for that, and you measure the fibrinogen, and the fibrinogen is 6 or 7, and the D-dimer is 800, and the ferritin is 4,000, then that all suggests to you, yes, this is likely that this patient will also have COVID-19. So these blood tests are very helpful in terms of helping you decide whether the patient could have COVID-19.
Very good. So I'm assuming if this patient was in getting screened on his hemodialysis center triage area, if you can complement your assessment with a pulse oximeter and assess if the oxygenation is below 85, then that would probably push you towards sending the patient towards the emergency room for further assessment, as compared to someone who has oxygenation within the normal range. Would that be a reasonable thought process, Professor?
Yes, so the issues for us are, if you imagine our cut point would be that if somebody had an oxygen saturation below 90% and that we think they're short of breath, then that's the type of person that we would then send for review in the hospital. If this oxygen saturation was 92%, etc., we would usually suggest to them, yes, if we have to dialyze you, we'll dialyze in the satellite unit, and then advise you to stay at home. And then only think about going to the hospital if you then become more unwell.
Excellent. Third question, how about home dialysis? Was there any significant difference between home dialysis patients, PD, as you compared them with the transplant population? Can you allude on home dialysis patients and their COVID exposure?
Yes.
And illnesses?
So at the moment, we only have one home hemodialysis patient in the hospital. It turns out they're not COVID-19 positive. They had a mechanical fall and fractured their sternum because they fell down the stairs. And she's COVID-19 negative. So none of our home hemodialysis patients have contracted COVID-19.
Excellent. What is the point behind asking the medical staff to self-isolate for 7 days only if they're having symptoms, but for 14 days if the contact had symptoms? Can you elaborate on that, please?
Okay, so if you imagine the time to develop COVID-19, the median time after exposure is 5 days. But the range tends to be up to about 11 days. So the issues are these, that let's say for the sake of argument, your son, let's say, developed symptoms of COVID-19. You're living at home with your son. Mm-hmm. So he, inverted commas, would be considered to be able to go back to work after 7 days if he felt well. But because you could take anything between 5 and 11 days for you to start becoming symptomatic, to ensure that you hadn't developed COVID-19 from a family member. That's why people were then asked to stay at home for longer.
Great. I'll go to the next question. If hemodialysis patients are at higher risk for COVID-19, so is there a proposal for all patients to be screened for COVID-19 routinely?
So what we are doing at the moment is that, yes, we are screening all our patients in all our centers, that there's hemodialysis patients for COVID-19. And the problem is that because the test is only going to tell you if they've got COVID-19 at that particular time, you're going to have to keep screening the patients. So to be able to do that, you have to have a system where you have enough tests to be able to repeat the tests on a regular basis. And until we have access to the antibody testing, that's what we're currently doing. Once we have access to more and more of the antibody tests, then we can turn around and say, yes, these patients all have antibodies to it, and then we'll stop screening those patients.
Thank you. I'll go to the next question. The question revolves around the transplant population from the mortality data that you had presented, Professor Davenport. It shows that the mortality rates are relatively lower. The writer indicates that probably more suspected and more susceptible to a higher mortality rate because they are immunosuppressed. What are your thoughts about these findings?
Well, this is a really interesting issue, because if you think about this disease, there are two components to this disease. There's the initial viral infection, and then there's the body's immune response to the infection. And so paradoxically, these patients who are taking immunosuppression may have less of an effect in terms of the immune response to the virus. One of the issues that we do though, is that if patients are on drugs such as azathioprine, mycophenolate, then these agents are stopped. And if for example, the patient was on tacrolimus and mycophenolate, because in the UK, our practice is to withdraw steroids. What we would then do is to withdraw the mycophenolate and give them a short course of about 2 weeks of oral prednisolone, about 20 milligrams a day, is what we do for our transplant patients. But on the other hand, you've got to remember that our transplant patients generally are younger and fitter than the vast majority of our hemodialysis patients, because by definition, they've been selected out for transplantation.
Thank you, Professor Davenport. I'm going to combine two different questions. One is whether you would advise to have a HEPA filter in the hemodialysis unit and use it in the COVID-19 suspected population. And the other question, do you recommend having an isolation room for the patients suspected or COVID positive patients within the dialysis unit?
So in terms of the masks, etc., we just routinely give our patients a standard surgical type mask. For the staff, we will give them a non-porous mask and a full face shield. If they're dealing with a patient who we suspect might have COVID or does have COVID, then they get a FFP3 mask, is what they do as a standard wear. In terms of when you're talking about patients coming into the unit. So in terms of coming into the unit, we've got to have a room where we can test patients one by one in terms of what's their temperature, what's their oxygen saturation, etc. And then we need to stream those patients into two directions. One, patients we think are fine, they're okay, and other patients who we think there might be a risk of COVID-19. So in that sense, there has to be some area in the unit where this can all take place, yes.
So HEPA filter, negative pressure room in that isolation room, or it would be just an isolation room?
No, I think that as far as we're looking at, we're just looking at a simple isolation room is what we're looking at. Because I think that if you put a mask on the patient and the staff are wearing appropriate PPE, then we think the risk of transmission is relatively low. Because I think that if you go back and look at our, say we nurse patients in our intensive care units, etc., we're not going to nurse all those patients in a negative pressure room, no.
Excellent. With the false negative rates for the nasopharyngeal swabs exceeding about 30% as you presented, how many times would you recommend to repeat the patient's swab? And I'll combine that with a question of my own. Would you look at nasal turbinate swabs as an alternatives, and what are your thoughts about that?
Okay, so the answer to the question is that if the first swab is negative, we would automatically do a second swab is what we do. If we're got really suspicious that we really think the patient is COVID positive, we may even do 3 or even 4 swabs. The point you've made is that now that testing has been made more generalized, we've actually had the Army setting up some testing centers. And obviously the Army aren't going to do swabs. They'll organize the testing center, and patients are then, sorry, not patients, but the public, or whoever attends those centers, are asked to do their own swab. And in terms of doing their own swab, they're asked or shown how to take a deep throat swab, and then with the same swab to take 2 deep nasal swabs. So you're right in terms of your nasal turbinates. Mm-hmm. But that's how testing is being done on a more generalized manner.
Excellent. I just want to clarify one element. When you repeat the swabs, would you space them at a 48-hour window or a 72-hour window, or would you just repeat it the next day?
So no. So the answer to your question is it depends on what I call the turnaround time. So because we've been using 3 different laboratories have different turnaround times. So if we had a negative swab in somebody who we suspect having COVID positivity, then usually we'd do it either after 48 or 72 hours. But that really is because of the turnaround time of different laboratories.
Excellent. I actually had approximately 100 questions posted. We spent quite a bit of time on about 50% of the questions. Unfortunately, we will not be able to go through all the questions. And I'll go ahead and move forward and introduce the second presentation. The second presentation is related to acute kidney injury and critical care nephrology during the COVID-19 pandemic. And again, the presenter will be Professor Andrew Davenport, and the floor is yours, Professor.
Okay, well, thank you very much. Thank you for the introduction. So I'm now going to talk about how we're treating these patients in our intensive care units. Now, we know that COVID-19 can be detected in the podocytes in the renal glomerulus and also in the renal tubules. And if you look, here's a picture of a patient who unfortunately passed away from COVID-19. And you can see here with these little stars, you can see debris within the renal tubules. With the little arrows, you can see some damage to the renal tubules appearing. But the most important injury are here with the arrowheads. And what you can see here is this pink material. And this is occlusion in a very small blood vessel. This is microvascular occlusion. So you can see one with this arrowhead here. You can see one again with this arrowhead here in terms of this pink material. And again up here. This is blocking off, clogging up very small blood vessels. And not surprisingly, people have reported an interstitial nephropathy due to the tubular damage. And very occasionally, people have reported a collapsing glomerulopathy, similar to what one can see in HIV. But most of the time, this is this microvascular damage. And if you look at patients who come in through the casualty department and you urine dipstick testing them, yes, you can find some blood, you can find some leukocytes and some protein. in quite a number of these patients who come in through the casualty. If we microscope the urine, we can see some tubular casts. Occasionally, the urine is positive for hemoglobin and for myoglobin in terms of muscle breakdown with the myoglobin. So one of the key issues in terms of the risks of acute kidney injury relate to volume depletion. Because often these patients have been at home, they've had a high temperature, 39 degrees, 40 degrees, they've not been very well, they've not been drinking fluid. And then we get this tubular injury. So in addition to any issues in terms of volume, we get microvascular injury. Occasionally we'll see episodes where we can detect free heme from red blood cell breakdown, and occasionally we'll find some myoglobin. And very occasionally, the patients will actually have frank glomerular injury. And so if you think about the risk factors are the fever, the ill health, because a lot of the patients we're seeing also have other comorbidities. So it's not just COVID-19, but it's COVID-19 in somebody with hypertension, somebody with heart disease, congestive heart failure, somebody with diabetes, etc. And obviously then there's the effect of drugs. What drugs are patients taking? Could they potentially be nephrotoxic? And the other issue in the UK is that we had seen pictures on the television of Italy, where Italian health services seem to be overwhelmed with patients and the need for ventilators. So when we started seeing these patients initially, if you imagine the policy from the physicians, the general medical physicians, was to keep the patients dry, to protect the lung. And again, initially, if you look at how patients are being managed in our intensive care unit, they'd often be on furosemide infusions, again, to keep the patients as dehydrated as possible, to try and so-called protect the lung. Press the button. Yeah. Okay. And so if you think about some of the drugs, obviously drugs that could make dehydration worse, increased renal tubular injury would be diuretics. But also one of the big changes in the practice of sugar diabetes is the use of SGLT2 inhibitors. And again, these cause sodium loss by the kidney. So they increase the risk of dehydration, besides things like non-steroidal anti-inflammatories. And then the question is, well, if you've got somebody who's got heart disease, should you stop the ACE inhibitor or ARB? Do they have an impact in terms of increased risk of renal damage? And then obviously calcineurin inhibitors, etc. And interestingly, if you look through the literature, the incidence of acute kidney injury vary from country to country, anything from 15 to 50%. And when we looked carefully at the data from China and from Italy, we were initially expecting AKI rates in our ICU of around about 20%. But we were initially seeing rates of 40 to 50% in our intensive care units. So much higher rates of acute kidney injury compared to previous reports. So what have we learned? Well, we've learned to avoid hypovolemia. And we now have an attitude that when these patients come in, we treat them as if they had sepsis. So if we think they're a little bit volume deplete, we'll now actively give them fluids back. We'll make them fluid replete. And the other issue in terms of the ICU management is that initially these patients were often managed as if they had ARDS and had high PEEP levels, 15 to 18 millimeters, etc. And in retrospect, we just wonder whether exposing patients to such high PEEPs actually caused a little bit of damage. And initially, what we found was the majority of patients with COVID-19 actually have very compliant lungs. And so you can often use a much lower PEEP of say 6 to 10 millimeters of mercury. But of course, in those patients who don't get better, who stay on the intensive care unit, say after 10 days to 2 weeks, then these patients then develop more classic signs in terms of similarities to ARDS, and they have deranged compliance and need higher PEEP pressures. But initially, the PEEP pressures one needs are often very low. And so in terms of considering renal replacement therapy, we don't rush to start renal replacement therapy. We'll do it if the patient is actively hypervolemic, if they're hyperkalemic, if there is a metabolic acidosis that we can't control, if the serum creatinine is rapidly rising, or if the patient is oligoanuric. So in terms of traditional starting points for replacement. And if you think about CRRT, What have we learned? We've learned that high volume exchanges increase electrolyte losses, particularly magnesium and phosphate. They increase the loss of antibiotics and other drugs, and they increase nutritional losses. And so what we found in the majority of our patients with COVID-19 is they're not particularly hypercatabolic. And a standard approach of 25 mils per kilogram per hour for CRT is fine for the vast majority of patients. In fact, many patients can actually have much smaller exchange volumes. And somebody asked me a little while ago, what about, you've got these patients on ventilators. The intensive care unit will often have permissive hypercapnia. Does CRT remove carbon dioxide? Well, here's a study from a few years ago looking at the amount of carbon dioxide removed. This is looking at hemofiltration. This is 1 litre an hour of hemofiltration. This is 3 litres an hour of hemofiltration. And this is then adding a bit of dialysis. So this is dialysis at 1 litre an hour, and this is 2.5 litres. So this is 1 litre of filtration and dialysis volumes of 1 litre, 2.5 litres, 3 litres of hemofiltration an hour, and dialysis of 2.5 litres. And what you can see is that by adding dialysis, there's a little bit of an increase in CO2 removal, but not very much. And actually, if you then look at the actual percentage of CO2 removed, it's actually very low. So CRT per se does not remove much of CO2. But one of the things that you have with continuous renal replacement therapy is the idea it is continuous. And so one issue is if patients are hypocoagulable, the circuits can clot. And what we found is that these patients can have high fibrinogens, certainly high D-dimers, high levels of factor VIII, factor and 1 Willebrand factor, factor 7, may have anti-cardiolipin antibodies. And so there are some reports of decreased antithrombin and decreased tissue factor pathway inhibitor. And what we found looking at our patients is this. In the patients who get admitted to hospital, sorry, let's go back. In the patients we have as dialysis patients who don't need to be admitted to hospital, then the fibrinogen and the D-dimers will be elevated. But the other clotting factors essentially are normal. In our patients who need to be admitted to hospital, who are symptomatic, we'll find the odd one who will have a raised factor VIII level, etc. But in those patients who get admitted to the intensive care unit needing ventilation, then these are the patients we find with the most deranged clotting profiles. So these are very hypercoagulable patients. And to give you an idea, this is called the thromboelastogram. And this is a test that we often use in liver transplant centers to see how the blood clots. And basically blood's put in a little pot and a paddle is put in the pot and the paddle goes round and round and the clot forms. So you have what's called the reaction time, or R, for the clot to form. And then the clot starts to form, and there's this thing called the K, which is when the clot reaches 20 millimeters, and then you have the maximal amplitude of the clot forming here. And so if you imagine the dotted line, this would be a normal patient. But in the COVID patient, you can see, firstly, that the clot is much quicker to form. And again, the thickness here of the clot is much thicker compared to the normal patient. And this is due to the effect of fibrinogen. So one of the issues in this hypercoagulable state is that we often find the patients may be systemically anticoagulated. Indeed, when we looked at a cohort of patients who we turned prone in the ICU, a number of those patients, ventilation did not improve in the prone position. And invariably, what we found on our CT pulmonary angiograms is that they had evidence of small clots in the lung, small pulmonary emboli, usually subsegmental. So if we've got a patient who's systemically anticoagulated, we initially start a CRT circuit without any additional anticoagulation. If they're not systemically anticoagulated, they'll be on prophylactic heparin, typically a low molecular weight heparin for us. And then the question for us is whether we then add a systemic anticoagulant for the circuit or a regional anticoagulant. Now, if you think about citrate, and the reason I talk about citrate is that in the ADKI documents and KDOKI documents, they suggest that the majority of patients in the ICU, citrate should be a preferable option. But if you think about citrate, we add citrate as a pre-dilutional fluid and here. And then the blood goes into the filter, and here is a dialysis circuit with dialysate going in here and coming out here. And we're looking to try and titrate the citrate to an ionized calcium post-filter. Now, you can see here, the levels I've shown here of 0.2 to 0.3 are very low levels. And that's because we found that at standard citrate levels of possibly going to 0.4, 0.5 millimoles per liter, circuits would clot. Now, there is one caveat, and that is this is a very low ionized calcium. And most blood gas machines are calibrated to an ionized calcium of around about 1. So to make sure that your machine can actually measure 0.2 and 0.3, you often have to ask your technicians to recalibrate the blood gas machine. So it does give you accurate results at these very low calciums. And then on the return line, they're having some replacement fluid going back to the patient. And then there's calcium being reinfused to the patient. So one of the issues with a citrate, it is a regional anticoagulant, i.e. the patient, the circuit rather, is only anticoagulated from here where the calcium goes. And so therefore the access point, the catheter, is not anticoagulated. And so one of the problems you have with CRRT is in the prone position. If you've got a femoral catheter in situ, you can't see it because the patient is face down. And therefore there may be kinking of the catheter, and that might cause circuits, particularly citrate circuits, to prematurely clot. So if we're thinking about systemic anticoagulations, then usually we're thinking about unfractionated heparin or low network heparins. So in terms of things, if we're not going to use citrate, we have to think a little bit about the circuit design for CRRT. So I said to you before, in patients, particularly those patients who are going to get turned prone, we're preferable to have a right internal jugular catheter as the access. We want to do pre-dilution because we want to reduce the hematocrit. We want to reduce protein content as blood flows through the dialyzer. And the dialyzer we want one with wider internal diameter fibers. So not all dialyzers are the same. Dialyzers designed for diffusion have very narrow fibers, very narrow diameter fibers. But here we want fibers with a wider internal diameter. And we want a dialyzer that gives us what I call an equal blood flow distribution. And I'll show you a slide of that in a second. And the other issue to think about is we want to carefully prime the circuit to minimize air-blood interfaces. Because if we have air-blood interfaces in the circuit, there's an increased risk of clotting. And obviously we want to minimize sites of turbulence in the extraorbital circuit to stop the risk of clotting. And so if you think about as blood goes into the dialyzer, if we remove fluid by filtration, then the hematocrit and total protein will increase. And this will increase the risk of clotting. And so if we think about the filtration fraction, we often simply think about, well, what's the volume coming out? What's the volume going in terms of mils per minute? But actually, the filtration fraction also depends upon the hematocrit and also the total protein content. So we want lower filtration fractions, i.e. lower hemoconcentration, to try and reduce the risk of clotting in these patients, certainly in the post-dilutional mode. Now, if you think about this cartoon, here is a typical dialyzer designed for diffusion, a narrow diameter capillary fiber, whereas this is a much wider, larger diameter fiber that we designed ready for hemofiltration. And this is the type of dialyzer design we want for our CRRT circuits to reduce the risk of clotting and hemoconcentration in these patients. Now, what I talked about in terms of how blood flow flows through a dialyzer, most standard dialyzers, the blood comes in through the header and then finds its way through the capillary fibers. And what you find is that there's a nice fast blood flow in the central fibers, but a much slower flow in these outer fibers. And therefore there's an increased risk of clotting starting in the dialyzer in these outer fibers due to the difference in flow distribution. So what we want is a dialyzer where the flow distribution is much more even. And there's less risk of clotting in the dialyzer. Now, this can be done by several different ways. Firstly, how the blood comes into the dialyzer, as to whether it is spread out almost like a watering can. And then in terms of the dialyzer design, whether there's a constriction ring, an O-ring, in terms of the casing, etc. So these are all issues in terms of how to choose a dialyzer for circuits to try and reduce the risk of clotting. And here is what I'm talking about by a blood-air interface. As you can see here, bubbles of air. So if you don't carefully prime the circuit, then you'll be left with these bubbles of air inside the dialyzer, and that's going to increase the risk of clotting in the dialyzer. So if we've got premature CRT circuit clotting, check the access. It may be it's an access problem with the access catheter, particularly a femoral catheter. If they're systemically anticoagulated and we're still clotting, then we may have to think about adding a regional anticoagulant, either citrate or a prostacyclin. If they're on prophylactic heparinization, then we may have to combine systemic and regional anticoagulants, heparin and prostacyclin, heparin and citrate, etc., to try and stop clotting in the dialyzers. Now, one of the issues I said to you before is that in the UK, we had much higher rates of acute kidney injury than we'd expected. So here's an example. You have a 13-6 bedded intensive care unit, a 13-bedded surgical HDU, but actually you're ventilating more than 50 patients because you've got a lot of patients that are coming into your ICU. So you've had to expand your ICU service. And there's a 40% acute kidney injury rate requiring renal support. We've only got 14 CRT machines. So one of the issues is, we haven't got enough machines to treat every patient. So suddenly, continuous renal replacement therapy becomes intermittent because you're going to have to use one machine to treat 2 patients. And then, of course, if you're going to treat one patient for 12 hours, another patient for 12 hours, you're going to use 2 circuits, 2 filter circuits. And of course, then there are the supplies in terms of all the sterile bags of fluid. And so in the UK, we ran into a crisis in terms of the supplies of the sterile fluids for the CRT circuits. So what are we going to do? Well, I said, fortunately, a lot of patients didn't have a high generation of urea and creatinine, and we could reduce the volumes. So often our patients were on 1 litre an hour exchanges. And then the other issue then is, well, what are the alternatives? If we're having problems in terms of supplying enough patients with renal replacement therapy, well, what about intermittent dialysis? Can we do intermittent dialysis in the intensive care unit? So the first thing to think about is it suitable to do intermittent dialysis in a patient? So you have to think about, well, how much fluid are we giving the patient? You know, what's the volume of antibiotics and other drugs? If there's an enteral feed, can we get an enteral feed that's low in sodium, low in potassium? So it makes us easier to provide intermittent dialysis because there's less fluid going to the patient, less electrolytes to sort out. And in terms of inotropic requirement, is the patient on multiple inotropic support? Or is there a dose of just single norepinephrine, in which case is the dosage stable or is it declining? Now, fortunately, in most of these patients with COVID-19, if they did require some norepinephrine, it was usually at very low doses. So most patients didn't require a large amount of inotropic support. And so what's the risk of intermittent dialysis? Well, the biggest risk is hypotension. Now, of course, it's going to be increased, the risk, if the patient is intravascularly volume deplete. It's going to be increased risk if they have pulmonary hypertension. It's going to be increased if they have a high PEEP. Then there are some issues in terms of some of the drugs we might give the patient, how we prime circuits, and obviously later on, in terms of whether we're trying to take away too much fluid from the patient in terms of excessive ultrafiltration. But one of the things to remember with intermittent dialysis is the first 20 minutes or so, there will be a slight reduction in oxygen exchange, and that's due to pulmonary leukosequestration. And the other issue to think about with intermittent dialysis is the bicarbonate. Because if you give or use a very high bicarbonate, there's going to be a rapid transfer of bicarbonate to the patient, and that may cause an increase in carbon dioxide, and especially if it's a patient who's already on permissive hypercapnia. So one of the things to think about is that there can be some reactions when patients are first put on a circuit. And one of the things that can be generated is something called bradykinin, which is a very potent vasodilator. And so what this graph on the right-hand side shows is this is levels of bradykinin in patients starting dialysis. As you can see, this is 0, 3 minutes, 6 minutes, 9 minutes, 12 minutes. So this bradykinin has been generated very, very early on at the start of the dialysis session. And all these patients here, patients 1 to about 17, are all dialysing with the same dialyzer membrane. And yet you can see there's some vast differences between patients in terms of bradykinin generation, with some patients generating almost none and others very high levels. And if you look here, this is looking at the reduction in blood pressure against the bradykinin. So essentially, the more bradykinin produced, the lower the blood pressure goes. And here in the dark dots is one particular dialyzer membrane, and in the circles is another dialyzer membrane. So even with different dialyzer membranes, it's still possible to generate bradykinin. So it's not just only one dialyzer makes or produces bradykinin. No, this can be done with other dialyzer membranes. And in terms of this risk of bradykinin production, this depends on charge. So it's going to be the more negatively charged the dialyzer membrane, the more likely you are to generate bradykinin. But heparin itself is very negatively charged. So giving a large amount of heparin can also make this worse. And then the reason I say about priming fluid is that if you use normal saline, that has a pH of 5.4. It's very acidic, and that can make things worse. And then patient factors such as sepsis, liver failure, etc., again, increase the risk of generating bradykinin and nitric oxide. And the other issue to think about is contamination of the dialysate with endotoxin. Now, it may be that in your intensive care unit, you have a running water, a ring main, and therefore you have fresh water running all the time throughout your dialysis unit, throughout your intensive care unit. But many intensive care units don't have running water all the time. And therefore there may be biofilm that develops in the pipes. And so if you suddenly decide to open up a water supply, suddenly you might get contamination from the biofilm that's been there for years. So these are all things to think about in terms of how prekallikrein is converted to kallikrein and forms bradykinin. And the other issue to think about is that even with our modern day membranes, you'll find there is a degree of leukosequestration. There's a drop in neutrophil and leukocyte counts early on in the course of dialysis, in the first 5 to 10 minutes. And if you track these white blood cells, you'll find they go into the lung and they stick in the pulmonary capillaries. And there will be a slight reduction in oxygen for around about 15 to 20 minutes into the dialysis. And then by an hour, it starts to resolve. So if we're going to think about how we're going to get around this, then how are we going to reduce the risk of hypotension? Well, at the start of dialysis, we could prime the circuits with bicarbonate. That takes away the acidity of the normal saline. If we're going to use an anticoagulant such as low liquid heparin, if we inject it into the venous limb of the circuit, then we don't get a sudden bolus going into the dialyzer. Or alternatively, if we wait between 3 and 5 minutes, you can inject into the arterial limb of the circuit. And because the dialyzer, by then, it will be slightly protein coated, and therefore there won't be the same reaction in terms of the bolus amount of heparin meeting the dialyzer membrane. We can again reduce the risk of hypertension by using pre-dilutional hemodiafiltration. And the reason for that is that this increases the amount of cooling and therefore increases endogenous noradrenaline and sympathetic nervous system activation. And that will reduce the risk of hypertension. And again, if we cool the dialysate down to a low temperature, such as 35 degrees, we use a high sodium concentration, and we use a low bicarbonate. And we use the low bicarbonate for 2 reasons. One, it reduces the shifts of calcium and magnesium and potassium during the treatment. And also, it reduces the risk of increased CO2 production in the patient. And again, we know from outpatient hemodialysis that once the ultrafiltration rate goes above 7 mils per kilogram per hour, then the risks of hypotension start to rise. So in these critically ill patients who might be on pressors, we set a target limit of about 5 mils per kilogram per hour. And if we want to remove more fluid, then we have to extend the time of the treatment session. And again, if you've got something on norepinephrine, The question is, should you increase the dose of norepinephrine to cover the first 10 minutes or so of starting dialysis? And just to show you with sodium, so here what we've done here is we've given a pulse of isolated ultrafiltration in this white area, in this cream area here. And we've then used different sodium concentrations in the dialysate. And what you notice is two things. Firstly, this is looking at relative blood volume monitoring. But the slope is much steeper with the lower sodium compared to the high sodium. And secondly, if you look at what I call the recovery is much faster with the high sodium compared to the low sodium. So one of the issues in the intensive care unit is if we're going to use intermittent dialysis is to use the highest sodium we can do. And the other issue is, what's better? Is hemodialysis better than hemofiltration? Or is it just how cold you make the patient? So here's an old Italian study looking at changes in blood pressure during treatment. And at the top, these two lines are to do with cold hemofiltration and cold hemodialysis fluids. Whereas down here is if they've used warm hemodialysis, that is at body temperature 37 degrees, whether it be hemodialysis or hemofiltration, with warm fluids, the blood pressure falls. Whereas with cold fluids, the blood pressure is better maintained, and it doesn't really matter whether it's hemodialysis or hemofiltration. This was post-dilutional hemofiltration. If you do pre-dilutional hemofiltration or hemodiafiltration, you get additional cooling. You get more cooling with the pre-dilutional mode. Now, what are the other alternatives? Well, if you have an intensive care unit that doesn't have a water supply, then what about a batch dialysis system? So here's the next stage system. And the next stage system has an advantage in that it can use domestic water, so your ordinary water. It will make a batch of dialysate. And there are some technical issues about the next stage system in terms of reduce the risk of clotting. So for example, the next stage system doesn't have the standard venous air chamber. And this is a blood-air interface. And again, what it doesn't have is an arterial chamber, where again, you can get a blood-air interface. You can see the froth here in the arterial chamber. And the other issue with the next stage system is you get very good cooling, again, which helps with cardiovascular stability. Now, what about peritoneal dialysis? So when we went to our intensive care colleagues and said, well, we're a bit short of CRT machines. And yes, we'll bring in some hemodialysis machines into the ICU, but what about peritoneal dialysis? Well, of course, our intensivists were concerned, saying, well, what about putting this fluid inside the abdomen? It's going to distend the abdomen. It's going to affect ventilation. What happens if they get a pleural leak? And also technical, can you do peritoneal dialysis if the patient's prone? What ultrafiltration do you get with peritoneal dialysis? What clearances do you get with peritoneal dialysis? So our intensive care colleagues had great concerns. Now, obviously, if a patient's had major abdominal surgery, we're not going to do peritoneal dialysis. Similarly, if they're pregnant, we're not going to do it in the ICU. And again, if they have a high oxygen requirement, an FiO2 of greater than 0.6, we're not going to do peritoneal dialysis. Again, if they have high pressures, high PEEP, we're not going to do peritoneal dialysis. And again, if the creatinine is going up by 100 micromoles per day, they're very catabolic, peritoneal dialysis is not going to really keep the chemistries under control. And then again, if they're very acidotic, we're not going to think about peritoneal dialysis. Now, fortunately, most of the patients we've seen with COVID actually don't have any of these criteria. Creatinine isn't going up too fast. They're on lower PEEPs initially. The FiO2 requirements are not as high as you might have thought. Now, technically, if we're going to put in a peritoneal dialysis catheter, we can't put it in with a laparoscope because laparoscopes generate aerosols. It's going to have to be done under a Seldinger technique. So to make it safe, we don't want a high INR, we don't want a low platelet count. And other minor concerns would be, does the patient have an aortic aneurysm, etc. And similarly, in this patient, already has a large pleural effusion. Again, we're not going to think about doing any peritoneal dialysis. And so one of the issues to think about is if you're going to do peritoneal dialysis, We've got to think about treating constipation. Now, most of us don't really think about constipation in the intensive care patient. But if you think about it, the patient in the intensive care unit is lying there, they're paralyzed, they're not moving. And so many patients in the intensive care unit after a few days will be quite badly constipated. So we need to treat that. We need to make sure the bladder is empty before we put in the PD catheter. We need to think about giving prophylactic antibiotics to cover catheter insertion. Many centers use vancomycin, and we happen to use teicoplanin. And then the other issue is, well, how much fluid to put in once you put in the PD catheter? So we generally start off with a low fill volume of about 1.6 liters. Initially, because we're not too sure how the catheter is going to work, we'll add a tidal component, say 90% tidal, and we'll have a relatively short dwell time of about 40 minutes. We traditionally will start off with 22.7 grams per liter dextrose solutions. And you're going to use 25, 35 liters in 24 hours because we're going to run this thing continuously to try and get control of the chemistries. And if you have to think about considerations, exit site care, we're going to put some mupirocin or gentamicin drops at the exit site. We've got to keep treating the constipation. What happens if fibrin starts developing in the effluent? We're going to add a little bit of heparin. If the patient's on antibiotics, we will also then give antifungal prophylaxis. And then once we've started the peritoneal dialysis, usually by day 2, we'll try and increase the fill volume to about 2 liters. And then it's a matter of what you're trying to treat. So if the main problem is hyperkalemia or acidosis, then we're going to do short cycle dwells. If we're more concerned about urea and creatinine clearance, then we're going to extend the cycle dwell time for a longer dwell to get better urea and creatinine clearances. And then obviously we're going to adjust the dextrose concentration according to fluid balance. And eventually we're going to change from, if you imagine, IPD to more CCPD treatments. And for those of you who are thinking about, well, what does putting fluid inside the abdomen do in terms of the pressure? So obviously in the ICU, patients are going to be supine. So here's some old data looking at putting in different fill volumes into the abdominal cavity and measuring the pressure. And this is centimeters of water. And so if we start off at about 1.6 liters, you can see this is less than 2 centimeters of water pressure that's been added. And here's 2 liters. And again, this is just over 2.5, possibly up to 3 centimeters of water. So these are very small increments in terms of abdominal pressure by adding the fluid. And what about if you look at pulmonary compliance? So here's a study from Brazil, and this is just showing you that there was no real difference in treating patients with peritoneal dialysis compared to hemodialysis over a course of several days. So please feel reassured that peritoneal dialysis does not adversely affect pulmonary function in these sort of like fill volumes. And so here's a picture of me leaving our ICU. And actually, I've just started a patient on peritoneal dialysis. So even on our modern day ICU, we actually had to resort to peritoneal dialysis because of the large number of patients we had to treat. So in summary, what we found was that there's great variation in acute kidney injury requiring renal replacement therapy between centers. And certainly in the UK, we had rates of between 40 and 50%. And part of this reason why there's such a big difference is we think is how patients are managed prior to the ICU admission. So in terms of treating hypovolemia, reviewing their medications, very important to try and prevent acute kidney injury developing. Once they're in the ICU, then most of us will use CRT. But the issue with CRT, as I said to you, is that these patients are often very prothrombotic. And therefore there may be complications in terms of premature circuit clotting. And the alternatives are intermittent dialysis or batch dialysis and peritoneal dialysis. And in terms of how to try and overcome the prothrombotic complications of these patients, to do a pre-dilutional mode for CRT or intermittent HDF. And the patients, you may be systemically anticoagulated. And the questions then are whether if they get repeated clotting, and it's not due to the access, it's whether we have to add in a regional anticoagulant as well. And thank you for your attention. So the key issue is to maintain your staff health and your own health and maintain full PPE in the ICUs. Thank you.
Thank you so much, Professor Davenport. An excellent presentation as usual. Just a few reminders for the audience. First of all, we are going to be uploading the talk onto the Saudi Society of Nephrology YouTube channel. So definitely you'll have a chance to look at it again, or have colleagues to look at it if they had missed the talk live. Another item is some of the questions we won't be able to answer right now because we have a wealth of questions, and we will be trying to answer them later and post them on the Saudi Society of Nephrology website. Thank you very much for the Fresenius company for sponsoring this meeting in affiliation with the Saudi Society of Nephrology. And with that, I'll be moving to the question and answer session. I have a question related to the COVID-19 routine check for corona virus. Do you have a protocol-based COVID-19 swab for both staff and patients, like the Germany program?
So the answer to your question is that we use the same swab for both staff and patients when we're testing inside the hospital. There's a different swab which is used, which is posted out to patients. So if you imagine in the UK, we have 3 different systems. First of all, members of the public can go to the UK National Health Service website and request a swab, and that will be sent to them in the post. And that is a slightly different swab and has a collecting medium in it. And they then take their own throat swab and nasal swabs and post that back to one of the government big testing centers. Secondly, in the hospital, we use the same swabs for both patients and for staff members. Then there is what I call screening centers where members of the public or members or healthcare workers can actually go and get a swab taken themselves. And again, that's a slightly different swab compared to the other 2, as it turns out. And then in terms of the actual testing, there are several different methods of testing within the UK. So as I said, we happen to have the National Reference Centre close to our own hospital, but there are other tests which are also being carried out as routine PCR tests. Now, some of those tests may be more accurate than others. That's certainly true. And so what we're trying to do in the UK now is to start to move from a test being positive to negative to actually quantitate the amount of virus there. Because again, one of the issues for us is to try and understand the pathology of this virus as to whether the patients who seem to have the worst symptoms and seem to do worse, whether they actually have more virus than other people. Mm-hmm. So I say, so hopefully we're now certainly with 2 of our centers moving to quantitate the actual amount of virus present on the swabs.
Excellent, thank you so much. There's another question related to patients with platelet counts less than 60,000. And you had mentioned that it's not in favor for PD, while we are looking at potentially placing a central line for CRRT. What are your thoughts and differentiating points between choosing these 2 modalities in the case of COVID-19 patients?
Well, firstly, although these patients are often very prothrombotic, fortunately, the vast majority of the COVID patients, the platelet count is normal. So, compared to something like hemolytic uremic syndrome, where you expect a very low platelet count, here you often find the platelet count is well within normal reference range. So we've not particularly encountered patients with very low platelet counts. Now, going back to the question here is that these patients are very prothrombotic. And therefore, we actually think that the issues in terms of inserting central lines, there's very little in the way of risk because of the prothrombotic nature of the patient. The key issue, though, is in inserting the peritoneal dialysis catheter, it's possible to hit an inferior epigastric artery. And that's why we just like to have a platelet count that's above 60,000 in case somebody actually hits an inferior epigastric artery, because you're doing this situation, if you imagine this is a blind technique with a cell-deemed catheter. And the inferior epigastric artery may vary from patient to patient.
Thank you so much. I'm going to combine a couple of questions. One is your thoughts about the CVV-HDF as an option for CRT modality. Do you believe that it has a higher potential to remove inflammatory cytokines and therefore might be better in this situation? And then the second question is related to slow, low efficiency dialysis as an option for in comparative to renal replacement therapy or intermittent hemodialysis.
Okay, so taking the first question first. So this is a question about, is it possible to increase the removal of inflammatory mediators by doing hemofiltration compared to dialysis? So your question is that the actual amount of cytokines removed doing standard volume exchanges is actually relatively small. And all you're going to do is remove free cytokines in the plasma space, in the plasma water. If these cytokines are actually active, they're actually active, if you imagine, at the endothelial level. So you're not really going to remove what is actually there, where the active inflammation is occurring. And if you think about it, if you look at the general amounts of cytokines, for every pro-inflammatory cytokine, usually there will be a compensatory number of anti-inflammatory cytokines. And usually by the time we see the patient in the ICU, if anything, there are more anti-inflammatory cytokines present than pro-inflammatory ones. So you're more likely to remove, if you imagine, both pro and anti-inflammatory cytokines per se. Most cytokines, although they're roughly small, like IL-6 and IL-8, cytokines such as tumor necrosis factor are quite large, at about 51,000. And most of our membranes don't have the pore size to remove that type of size molecule. Because once the membrane's been running for an hour or so, it gets protein coated, and therefore the size of the actual pores gets smaller. And therefore, most of the time, you're removing molecules around about probably up to possibly 15,000. So the actual amount of cytokines you're actually removing in 24 hours compared to the production rates is actually a very small amount. And therefore, to me, there's no real difference between dialysis or filtration in terms of trying to remove anti-inflammatory mediators. Technically, there will be a slight increase in a filtration mode. You can possibly increase that by doing pre-dilution in terms of removing additional cytokines, but the actual amount to have a clinical effect is minuscule. So I don't think I don't think that really helps. The second question was, what about doing intermittent dialysis? So different people call the same thing differently. I think I like to call it PERT, or prolonged intermittent renal replacement therapy, rather than slow, low efficiency dialysis, because slow, low efficiency dialysis doesn't sound very good, does it? You're not going to sell somebody saying slow, low efficiency. But prolonged intermittent renal replacement therapy, I think, is very good. As I said in my talk, one of the things we will do when we do intermittent treatment is we'll say, right, we're only going to remove fluid at 5 mils per kilogram per hour. So if that means we've got to treat somebody for 6 hours or 7 hours, then we're going to treat somebody for 6 or 7 hours. And I think the issues are that if you use like the batch system, like the next stage system, which is often used in the US, then again, you'll find these are elongated treatments. Mm-hmm. They provide cardiovascular stability. So I think in that sense, these are good treatments. And the problem we had in the UK is we, in the end, didn't have enough machines, RT machines, to provide a machine for everybody who needed one, 24 hours a day, 48 hours, 72 hours, etc. So we had to therefore look at alternative methods of treating patients. Now, there are some slight differences, and the differences would be in terms of things like antibiotic replacement, removal. So you're going to get slight differences in terms of possibly dosing antibiotics, etc., if you're doing PERT, or you would call it slow efficiency dialysis, compared to CRT, etc. So there are some slight nuances there in terms of how you prescribe antibiotics.
Thank you very much. I'll go to a question related to a patient who has a lung injury attributed to ARDS. And with the more evidence that we now learn about this disease with causing more thrombosis in the lung vasculature, is that complication going to make us more inclined to keep the patient on the dry side, or will this make it more of a vicious cycle? Your thoughts, Professor Davenport?
So two things. What we have seen is that in the slide I showed you, where there was this like microthrombi in the kidney, we certainly have seen patients who have the same process in the heart. And so it's not really like a myocarditis, but it is severe myocardial injury. And on scans such as an MRI scan of the heart, these come out as showing small little dots of injury. So this clotting, especially in small blood vessels, is a key issue in the really sick patients with COVID-19. So what we would have in our patients where we thought there was clot in the lung is that these patients would be systemically anticoagulated. That would be our number one issue, would be systemic anticoagulation. Mm-hmm. Now, you've then said to me, well, what about trying to reduce lung injury? Well, I think that one of the issues in the UK is that we went into this epidemic with the view that we had to try and prevent people being ventilated. We had to try and prevent lung injury. And I think that's why the general physicians who manage patients coming into the hospital erred on the side of not giving these patients fluid, on the basis that the chest x-ray looks as though they could have interstitial infiltrates. Interstitial infiltrates could be infection, they could be fluid. And therefore the clinicians were very conservative in terms of fluid replacement, on the basis that if we keep the patient dry, we'll save the lung. And unfortunately, the kidney seems to get a little bit worse. So that didn't seem to work. And therefore we went back to the saying, well, actually, these patients often behave as though they've got sepsis. So let's treat them as though they've got sepsis. Let's resuscitate them. Let's give them fluids back if we think they're a little bit volume deplete. And I think that by changing that, we've seen two things. One, the number of patients developing acute kidney injury now is much lower than it was at the start of the epidemic. And secondly, the number of patients we're now ventilating is much less than we were at the start of the epidemic. So I think that actually two things. One was letting these patients get too dehydrated, I think increased the risk of these microthrombi in the lung. Mm-hmm. I think the other thing was that we probably tried to ventilate these patients too hard with too much PEEP at the start. But I think by changing practice, we've seen less lung injury.
Excellent. Thank you so much for this insightful and practical approach to such a case scenario. I have a very interesting case. It's a 68-year-old hypertensive patient, lives in Sudan, presented to the ER about 2 weeks ago with a history of high-grade fever, diagnosed with malaria and a simple urinary tract infection. About 4 days ago, developed severe shortness of breath, and when arriving to hospital, the oxygen saturation was at 75% and a EKG done diagnosed as ST elevation MI, and they began the protocol for myocardial infarction. The patient is again suspected with COVID-19. After 1 day, the saturation deteriorated to 45%. He's now under mechanical ventilation just about a day ago, and now he is anuric with a creatinine of 5.1. What would be the best action for a treatment plan for this acute kidney injury? I think you've alluded to several options based on available resources, but if you can elaborate a little bit on this case specifically. Thank you.
Okay, and the malaria has now been treated. That would be correct.
I'm assuming so, because that was the initial diagnosis about 2 weeks ago. The case does not describe that. It is from Mohammed Zayad. Well, okay. If you're on the call, he can unmute and give us more insight. But let's assume that the malaria was treated.
Okay, so we've got a patient who is becoming anuric, has got a rise in creatinine. And so the issues to me is that what treatment can I offer this patient that's going to cause least damage to his lungs, least damage to his heart, etc. And so to me, I would normally start this type of patient on some form of CRRT. And the reason I say that is that by doing something continuously over a longer period of time, it allows us to have greater stability in terms of cardiovascular function. There's going to be less changes in things like bicarbonate. I said to you before that if you use a high bicarbonate and do intermittent, say, dialysis, then you risk the CO2 rising. And if this patient is difficult to ventilate, his PO2 was low, it may be if he's on high PEEP, etc., there's a ventilatory issue. And again, if the patient's on a high percentage of oxygenation, high pressures, then again, things like peritoneal dialysis are not going to be quite so helpful. And in terms of intermittent dialysis, if a patient's on a high PEEP, the problem with a high PEEP is it causes a reduction in blood supply coming back to the right side of the heart. And one of the problems we have is that when we connect somebody to a hemodialysis circuit, then there tends to be some pooling of blood, again, in the capacitance venous vessels. So again, a reduced return of blood to the right side of the heart. So the combination of a high PEEP and what I call conventional type of intermittent dialysis, there's going to be an increased risk of hypertensive episodes because there's a reduction in blood supply back to the right side of the heart. And in that sense, that's why I prefer a form of CRT, often with just low cycles, perhaps a 1.5 litre hourly cycles, I think would be my preferred option.
Thank you very much. I'll close the Q&A session with one question related to PD. A COVID positive patient who is now on PD, and the question is whether the effluent solution is considered an infectious waste, specifically, of course, with shedding of the COVID-19 virus. And if it is positive, would you recommend a specific methodology of disposing of this product?
Well, that's a really interesting question. So although we think of COVID-19 being a respiratory virus, it does actually go into enterocytes. And so it is possible to recover the virus from peritoneal dialysis effluent. You're absolutely right. Now, the issue, of course, is, well, what's the concentration in the peritoneal dialysis effluent? And the answer is very, very low. But the issue would be this, that we would recommend that in patients who are COVID positive, that there are some precautions taken. And in terms of the intensive care unit, we would put the waste fluid down the same drain as we put down the CRRT fluids. And then we would also then usually treat, having poured it down what I call the sump drains, is then we'd normally also put in some bleach afterwards. And again, we'd ask our healthcare workers who are dealing with this to treat it as a potentially infectious fluid. Yes, is the answer to your question.
An excellent two presentations by Professor Davenport. It's a pleasure to have you with us at the Saudi Society of Nephrology, and hopefully more sessions to come with you. I want to remind all the audience that we do have a couple of upcoming meetings also related to COVID-19, speakers from the US, both on the 16th and on the 18th of May. So stay tuned for the upcoming two sessions, and hopefully you can join us then. Thank you very much. I will leave it to Professor Mitwalli if you have any additional items to close before we close the session.
Thank you, Sam. Thank you, event group, and thank you, Virginius, for their great help and support. And you have done a good job, all of you. Thank you again, and hope to see you very soon.